So yeah, again, welcome to everybody. This is MedCognito's TDM exam prep review, and we are here to, share thoughts on how to prepare for this all-important exam, the TDM exam, okay? So the first thing is we have to let candidates know what they are going to expect in the exam. And the TDM is totally different from the MCCQE1 and the NACOSKI exam. The TDM is an exam on its own. And most of the time, those who write the TDM exam are candidates who are going into the practice-ready assessment. All right. So if you have no idea about it today, I just want you to know those who want to go into the practice-ready assessment, that is those who don't go through the residency route, but are already practicing physicians in their home countries, and they want to get into family medicine, especially. This is an exam you want to focus on as well, apart from your MCCQE1 and your NACOSKI. Okay. Then, what are the candidates' concerns? We will solve a lot of questions today, so we can get a very good glimpse and a very good view of the whole thing. And there's a special announcement for the upcoming class, which is about to start very, very soon. So please, I want to suggest that let's all mute ourselves so we can all enjoy the class. So how are we going to ace the TDM exam with no stress and overwhelming study material? How are we going to do that? First and foremost, I hear a lot of candidates talk to me. Oh my God, Dr. Brony, I don't know what to do. This is my story. I am overwhelmed. I am stressed. I don't know how to study from the CTC. The CTC is a very, very big book. I should have brought my copy. It's a very, 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 very big book. Okay. And that is one of the reference materials, not the main reference material, but one of the reference materials which a lot of candidates use to prepare for the exam. So it's very big. It's a very, very big book. But the point I want you to understand is that, you know what? You can ace this exam. Now, let's go back. You know that whenever I'm teaching, we focus on what the exam is all about. Unlike the QE1, which has 210 questions in the morning and 38 questions in the afternoon, the TDM has just 40 questions. Just 40 questions. So, I always tell people that, look, the TDM is not a difficult exam. If you apply yourself to it and you follow everything we teach, you should be able to ace this exam easily. It has 40 questions. And the 40 questions are going to focus on, number one, health promotion and illness prevention. That's one. Number two, acute cases, so like emergency medicine situations. Then number three, like chronic cases. Then they will also focus on drug safety, okay? Drug safety. And then when you go to the therapeutic interventions, the exam usually will focus on pharmacologic, non-pharmacologic, pharmacologic, non-pharmacologic. So, for example, let me show you. In the exam, you're going to get about 70 cases or 70 questions asking you about pharmacologic issues, and 30 of them will focus on non-pharmacologic issues. So you remember that I said that the exam is 40 questions, but under those 40 questions, at times you can have sub-questions, and that is what makes up the 100 questions, all right? But then in reality, it is, say, one question, and then you have A, B, C. So you add the A, B, C, and so that's one question then becomes 3 questions. And out of that, the 70% of the questions will be focusing on what's your pharmacologic management? What's your pharmacologic management? What's your pharmacologic management? And then the rest of the 30 will focus on non-pharmacologic management. Non-pharmacologic management. Now, when it comes to how the dimensions of care are distributed, the questions will focus more on chronic disease management. So maybe somebody with diabetes, like I'm talking about chronic conditions, right? COPD, congestive heart failure, atrial fibrillation, like those ones which are, ongoing conditions. And then you'll also get about 12 out of the 40 questions focusing on drug safety and adverse effects. So drug safety and adverse effects, we are talking about things like drug-to-drug interactions, if you are using warfarin, what medications will you want to be careful about, those kinds of things. And then the acute is emergency medicine cases. Then after that, health promotion and illness prevention, which may deal with, things like immunization, things like, reporting to public health, those things. It should be about 6 of those cases. So if you want to master and do very well in the TDM exam, make sure that at least you are very strong on chronic disease management. You are very strong on drug safety and adverse effects. You are very strong on your acute medicine, like emergency medicine stuff. And then these are common emergency medicine stuff. It's not like some wild, serendipitous cases which people can't manage. No. These are regular, everyday cases that a regular family physician in Canada should be able to deal with. Doctors, please, can I proceed? I want to ask, can I proceed? Hello, can I proceed? Can I? Okay, sure. Okay, sure. All right. So just continue. So when we're talking about health promotion and illness prevention, basically it talks about the process of enabling people to increase control over their health and its determinants and thereby improving their health. Illness prevention covers measures not only to prevent the occurrence of illness, such as risk factor reduction, but also to arrest its progress and reduce its consequences once established. Okay. And then acute illness, that is brief episode of illness within a time span defined by initial presentation through the transition of care. So all the various cases which can present to the emergency room that you need to deal with, those are the acute conditions. See, like if you start from neurology, severe headache, why do people come to the emergency room? Seizures, stroke, why do people come to the emergency room? Why do people come to the emergency room with gastro concerns? What gastro concerns do people come to the emergency room in Canada with? What, ophthalmology concerns do people come with? So those are the acute conditions, right? And the chronic conditions will still fall under these systems, but then these are conditions which progress over a period of time. And then after that, we go to the drug safety and adverse effects. That is the unintended or the harmful effect resulting from a medication or other intervention. So you know that there are some foods which we eat which can react with some medications. These are the things you want to start thinking about when it comes to safety and adverse effects. Okay, so then remember I told you that there's the pharmacologic and the non-pharmacologic part. So with every acute case, think about what are the pharmacologic things I'll do? What are the non-pharmacologic things I'll do? For every chronic case, think about what are the pharmacologic things I'll do? What are the non-pharmacologic things I'll do? That is how you have to put your learning so far as the therapeutics is concerned. Therapeutics is not focused on pathophysiology and those things like the QE1 is. Therapeutics is basically pharmacologic, non-pharmacologic, pharmacologic, non-pharmacologic, pharmacologic, non-pharmacologic. That is it. Okay. So in terms of the topics, which topics will come regularly? Look, the topics come across family medicine topics as broadly as possible. And what's the complexity? How complex are the patients? About 10% of the cases will have patients with multiple comorbidities. Okay. But about 90% of the cases will be straightforward cases. And then age groups, you realize that they also will focus on people from all age groups. So from the cradle to the grave, that is from the newborn till the person becomes very old and die. And what about gender? So you're going to say that, oh, I'm going to focus on conditions which affect males more. I'm going to focus on conditions which affect females more. No, there's a balance between male and female. It is evenly distributed. At times it can be 50%, 15% male, 50% female. At times it can also be 40% male, 60% female, or can be 60% male, 40% female, depending on the cohort you are in. But remember that the questions are going to come from newborn children to elderly people who are dying. The complexity, most of them, it will be a straightforward case, but occasionally you may get, about 10% of the cases. So that's about 4 out of the 40 may have, a patient with multiple comorbidities. And for the age groups, it cuts across. Okay. So far, initially, the exam was written twice a year, but it looks like from 2023, 2024, they are making it 3 times a year. So the first batch of candidates already wrote the exam. They are done. They did it on January 17th. The next batch will be on June 5th, 2024. Then the next batch after that will be September 25th, 2024. So I have a question. If anyone has any question, you can ask before I proceed, because we are now going to get into the meats and the nuts and the bolts of TDM exam itself. Anyone with any question? Anyone with any question?
Dr. Bruno,
Yes.
please, I have a question.
Mm-hmm.
I am quite confused about the category of IMD that actually qualify to take the TDM.
Mm-hmm.
Yeah, because I went through the website. I know family physicians, there's people who have completed residency
So
actually
your
qualify.
voice is breaking. Dr. Yama, your voice is breaking. Can you just repeat your last sentence?
Okay, I said I went through the website and I noticed the family physician, that's candidates that have completed their residency program, family medicine, qualify for it. From what I've gathered, I learned people who have gone through 2 years of residency training in family medicine actually qualify for it. And then another thing I've learned over time, I've heard some people say those that have done 1 year of housemanship and 1 year of independent practice can actually may qualify for it. I'm not sure.
No.
And then for some other people say, I know in Ghana, housemanship is 2 years, but in Nigeria, housemanship is just 1 year. So there are a lot of conflicting information out there.
Okay.
So yeah, which is why I'm asking. Because okay, on my own part, I actually did 1 year of housemanship in Nigeria, and then 3 years of practice as a medical officer. So I'm really not sure if I qualify for the TDM.
Beautiful. I think what we'll do is that let me pause it here and then take you to the SIPA page, okay? Because that will solve a lot of your questions. Because so far as you've done independent practice, that also qualifies you some way, somehow. But I'll just take you there so you understand what they focus on. So let me share my screen just so that we can clear that doubt. So this is it. The pre-screen eligibility. And this is very similar for almost all the provinces. Of course, some provinces have maybe a nuance here. We want you to have done this rotation, blah, blah, blah. But in general, it says, listen, successfully completed postgraduate or internship. And when they say that, it also refers to housemanship as well, okay? Or residency training in family medicine. That's a minimum of 12 months. So Dr. Yama, that's number one. You are required to have a minimum of 8 weeks of postgraduate training in the required rotations in general surgery, pediatrics, internal medicine, obstetrics and gynecology, as well as training in psychiatry. Now, if you are deficient in some of the rotations, you can prove that you have experience practicing in the area of deficiency as an independently practicing family physician. The college may accept this experience in lieu of your training. So that is, yes, we have a lot of people, candidates from Nigeria coming through the practice ready assessments in the various provinces. And yes, the colleges know that you did just 12 months. However, because you've done independent practice, and for your situation, you've done it for 3 years and even more. So look, you don't have any problem at all. And then look, the other point is, have 3 years of full scope practice as a family physician or general practitioner. That is basically that. If your postgraduate internship training program was less than 24 months in length. So our brothers and sisters from Nigeria and any other country where they did not do 2 years of housemanship or 2 years of internship, this is where you qualify.
Okay.
Yeah, it's simple. It's simple. Don't overthink it. Please, does anyone have any other question about this before I move in? Because I know it's a question on many people's minds. But look, as somebody who has taught all these candidates all these years, I've so many Nigerians have, and they are very wonderful physicians as well. So if your internship was less than 2 years, but you've practiced for a number of years and you apply, yes. Because chances are that in your practice, you might have met some of the cases you did not meet during your internship and you still manage them. Please, are you getting the whole point? That is all that the whole thing is about. Don't overthink it. All right? Did I put your concerns to sleep?
Yes.
Yeah. So it's good. Okay, sure. So let's go back. So yeah, so the next batch of students are preparing for the exam for June 5th, 2024. Then after that, so June, then July, August, September. Okay. So that's how it goes. All right. So what competence level should you be aiming at? The competence level for this exam, you should be aiming at as a practicing independent family physician in Canada. So basically, the essence of the TDM is that if somebody is a family physician in Canada, okay, if somebody is a family physician in Canada, they should be able to solve the questions you are solving. And somebody said I should not forget to record it. I'm recording it. Don't worry. After that, we'll send it back to you. Okay. Okay. And then where can you take the exam? You can take the exam at a prometric center in Canada or by remote proctoring. And by remote proctoring, that means you can do it in the comfort of your home, so far as you have good internet access, and then you're good to go. Okay, sure. So how will you be examined in the TDM exam? How will you be examined? As I've told you, that you should focus your examination on health promotion and illness prevention. So that like public health and its related issues. Acute illness like emergency room situations, how to write admission orders, when to refer a patient, when to consult a specialist, and then chronic illness, that is chronic disease management. So just sit down and you can even pick your Toronto notes, the book everyone likes. You can even pick your Toronto notes and ask yourself, okay, in neurology, what are the cases which are chronic conditions? Okay, amyotrophic lateral sclerosis, multiple sclerosis, what are the cases which are also acute? Maybe very bad case of acute migraine, very bad case of stroke. What are safety profile of medications? What are medications that I need to know? What is their safety profile? For example, what medication will people be concerned about if maybe a patient is taking green leafy vegetables? We all will know that it's maybe, warfarin and all those things, right? Which drug-to-drug interactions should I be concerned about as a family physician? You must also know some drug classes as well. Okay, some drug classes must also be known. And then you must also know how to write prescriptions in the Canadian context. And all these things, we teach them. We teach them in class. And then don't only learn first-line medications. Also learn second-line medications, learn third-line medications as well. And then learn adverse effects of medications as well. And then you also have to learn some alternative therapies that candidates tend to fall back on. And then what is a therapeutic contract? What conditions or what medications will a patient need a therapeutic contract for? And then you must also learn some things about drug abuse, drug misuse, and how to deal with them. Because remember, we are in Canada, there's an opioid crisis going on. So if you're preparing for an exam, you want to make sure that you also learn everything which is happening around you, so far as prescriptions and medications are concerned. So this is a 3-hour exam, 40 cases. As I said, there are about 2 to 3 sub-questions per case. And in the long run, it comes to almost 100 cases in total. Almost 100 cases in total. All right? Good. Now, there are 4 attempts in all. You can only attempt this exam 4 times. So the stakes are high. And you can have maximum of 2 passes 2 pass results per lifetime. So if you pass the first exam, I think you have 2 years to make sure that you get into practice. You get into practice. If you don't get into practice, that exam goes away. Unlike the Q1, that's when if you pass forever. For the TDM, if you pass after 2 years, if you've not gotten into practice, you need to retake it again. And if you take it again and you pass again, that is it. And you may attempt the examination in the following calendar year. So, when we say that you can write that the exam will be written 3 times this year, if a candidate fails, they cannot just jump on to the next exam date in September. So if somebody writes the exam in June, or somebody wrote the exam in January and the person failed, the person cannot jump onto the exam again in June or September. The person has to wait for the full calendar year. And you cannot apply to consecutive examination sessions. So, for example, I said somebody wrote the exam in January. That same person cannot apply to write the exam again in June when they get their results and maybe they're not very happy with it. Okay. And the issue is that you have to follow Canadian guidelines and best practices. That is all you need to know. So how are we going to ace the Q1, the TDM exam? Number one answer per line. One answer per line. Let me say it again. One answer per line. I really want to drum this into the heads of all our candidates. One answer per line, okay? And provide only the number of responses that are requested. If they want 3 responses, provide only 3 responses. If you provide more than 3 and you provide 4, 5, 6, even if your answer is correct in 6 and your answer in 1 is wrong, they will only mark the first 3 and then they leave the rest. And then you may also get a situation where you have to just provide that this patient does not need any treatment. That's also fine. It's also an answer, okay? And points are not deducted for incorrect responses. So if you give a response and it is wrong, you're not going to get a point deducted from you. And then you want to also be brief as possible. And you also want to be specific. When I say specific, what I mean is say hypothyroidism or say hyperthyroidism or say Graves' disease instead of saying thyroid disease. Doctors, is that okay? Is that clear? Can I move on? Okay. And the other point is that we said about 70% of the cases will be about pharmacologic management. So ask yourself, is this question asking about a drug class or is it asking about a drug name? Because, for example, if they ask, what drug class will you give? And you go and write your answer, pantoprazole. Wrong. Pantoprazole is a proton pump inhibitor. So if they ask, what drug class will you give? Rather go pantoprazole. Rather go NSAID. What drug will you give? Okay. Sorry. What drug class will you give? Not pantoprazole. Proton pump inhibitor. What drug will you give? Pantoprazole, esomeprazole, rabiprazole, lansoprazole, or Aleve Advil. But drug class, NSAIDs, proton pump inhibitor, big one-eyed, sulfonylureas. Doctors, please, are we all on the same track? Yeah. And the other trick is, please, don't provide a range. Never do that. Never provide a range. Never say, I will give amoxicillin 500 milligrams TID for 5 to 7 days. No. Look, we all know that some medications can be given for 5 days. They can also be given for 7 days. And so far as what you are writing is standard practice, you'll get an answer right. So you can have somebody writing that medication for, say, 5 days, and another person writing also that same medication for 7 days, or somebody writing it for 7 days, someone writing it for 10 days, or someone writing it for 10 days, somebody writing it for 14 days. So far as it is standard practice, you get the answer right. What about spelling mistakes? So far as the examiner is able to pick up that Dr. Zoe, Dr. Ineka, Dr. Eugene, Dr. Asma are writing this particular medication, she might have missed an A or a B or a C or a D or a Z. But so far as every sane person can pick it up that, look, the person is trying to say this. you're going to get it correct. And then what about abbreviations? Some abbreviations are known by doctors all over the world. In fact, all over Canada. So if you use an abbreviation like that, sure. But if it's an abbreviation used in your local hospital from back home, and it is not common in North America, I'll suggest that you avoid it. And so as much as possible, please avoid abbreviations if you can write the answer in full. What are the materials you need to study? Number one, Canadian Patient Safety Institute, safety competencies, World Health Organization. They have International Statistical Classification of Diseases, Alberta Health Services. They have a book. I have one. It's called Bugs and Drugs. Okay. Then Up to Date as well is a very good resource. And the Public Health Agency of Canada, especially because of the preventive health stuff we're talking about. And the Public Health Agency of Canada, that is the Canadian Immunization Guide. So that tells you that you must master immunizations. Those immunizations which can be given in high school, those which are given in little children, those who are given in neonates, and then those which are given based on the person's age, maybe 65, 50, and all those things. You must learn all of them. So yeah, Dr. Lika is asking that it looks like the CDM part of QE1. Yes, some way, somehow, but this one goes a bit further. The CDM, there are times they can have about 30 options and you have to choose 2 of them. This exam does not have that at all. It does not have that. And this exam is basically, in the CDM part of the QE1, at times we focus on maybe even physical exam and all those things. This one is basically therapeutics, management. Yeah. So that is it. So somewhere it looks very similar to the TDM, the CDM portion of the QE1. But the CDM portion of the QE1 will not also really go into drug doses, right? But the TDM will focus on drug doses. And then you must also look at the College of Family Physicians of Canada. They have priority topics and key features. Currently, they have 105 topics, okay? So if you're able to master those 105 topics and learn the management for each of them, you're good. And then Choosing Wisely Canada and Canadian Medical Association Journal and RX Files and Compendium of Therapeutic Choices. In fact, the last 2 books are, the common books that a lot of candidates love to use, okay? So we're going to now start a battery of questions. I want somebody to read the first case for us. I need a volunteer to read the first case for us, please.
Yeah, I can read it. I can read it now.
Mm-hmm.
Hello?
Mm-hmm.
A 56-year-old patient on pantoprazole for acid reflux and currently on the 7th of the 10th course of oral ciprofloxacin for an infection comes into the clinic with a history of 4 days of watery, foul smelling diarrhea. Is
So your line is breaking. So a 56-year-old patient on pantoprazole for acid reflux currently on day 7 of a 10-day course of oral ciprofloxacin for an infection comes into the clinic with a history of 4 days of watery, foul smelling diarrhea. Patient is hemodynamically stable. What is your diagnosis? What's your diagnosis? Can somebody tell me? What's your diagnosis?
Diarrhea caused by C. difficile.
Okay. So diarrhea caused by C. difficile. Beautiful. Diarrhea caused by C. difficile. Okay, good. So that's C. difficile infection. Okay, good. Next question. The same patient. What medications can you prescribe for this condition? Indicate the dose and the routes. Can somebody help me? So in other words, this question is asking about management of C. difficile infection. What would be your answer? Management of C. difficile. What medication options do we give? So C. difficile, we can give vancomycin, 125 milligrams, QID PO times 10 days, or QID PO times 14 days. Look here, I said ranges were written for teaching purposes. In an exam, choose a single duration and stick to it. Choose a single duration and stick to it. Number 2, metronidazole 500 milligrams TID PO So PO means by mouth, right? Oral, for 10 days or for 14 days. Again, don't write your answers in ranges. Don't write 5 to 10 milligrams. Don't write 10 to 14 milligrams. Just write 10 days, 14 days, 7 days, 5 days, 10 milligrams, 125 milligrams QID. All right. And then there's another medication we call fidaxomicin. 200 milligrams twice a day for 10 days by mouth. Okay, because the question said in an exam, the question was asking for the dose, the route, and then the duration. Okay, so this same patient who took the Cipro and has the diarrhea, the patient inquires about loperamide to stop the diarrhea. What will you advise? Who can help us? Somebody has C. difficile diarrhea, and the person is asking for loperamide to stop the diarrhea. What will you do? What will you tell the patient? Hello, doctors. The class is too quiet today. I'm not happy about it. What will you tell the patient? Hello, what will you tell the patient? C. difficile diarrhea, and the patient wants to get loperamide. What will you tell the patient? Good. So people are telling me anti-motility drugs are discouraged in the context of C. difficile infection. Anti-motility drugs, they are contraindicated or they are discouraged in the context of C. difficile infection. Okay, good. So what is your next step after prescribing the medication you decide on in question 2? So you've diagnosed somebody with C. difficile infection. You've given, say, the person some vancomycin orally. What's your next step? Can anyone help me? Can anyone help me? What's your next step?
Rehydration.
Rehydration, okay. So remember that we said that the patient was on oral Cipro. So you want to stop that, right? You want to stop the oral Cipro. And then, of course, you want to rehydrate the patient. But remember the question said the patient is hemodynamically stable, right? Okay. Next question. How could the above condition be prevented from occurring? How can C. difficile infection be prevented from occurring? Anyone? How can it be prevented from occurring? How can C. difficile infection be prevented from occurring? How can you prevent C. difficile from occurring?
Minimizing antibiotic use.
Minimizing antibiotic use is someone's answer. Or it could have also given probiotics, right? Could have given probiotics as well. So you can prevent C. difficile from indiscriminate antibiotic use, and then you can also give probiotics as well. Doctors, please, are you tracking with me? Are you tracking with me? Track with me, track with me. Are you tracking with me? If you're tracking with me, just type yes, 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 so that I know you're tracking with me. I'm not just here to discuss questions, and I want us to make sure that we get what we are learning. We get it. We get it. We are appreciating it. And we are getting prepared for this exam. Okay? Good.
Okay.
Sorry, doctor. Question.
Yeah.
How about limited use of pantoprazole? So and in general, people.
That's another thing. If you diagnose somebody with C. difficile and the patient is on a PPI, unless it's so important, stop the PPI as well. Beautiful. Thank you very much for that. Thank you.
Thank you.
Sure. Can you read this case for us, please? Since you're already on the line. Can you read this for us?
Yeah, sure. A 46-year-old male comes into your clinic inquiring about having a dental procedure. He used to use IV drugs and states that he was admitted to the hospital 7 years ago and treated with antibiotics for a life-threatening heart infection. What will you prescribe for him?
Okay. So what will you do? Somebody is going for a dental procedure. Yeah.
Amoxicillin.
Amoxicillin, what dose?
500 milligram 3 times per day. I think 3 days before or 1 day before start of the procedure or something like that.
I think it's an hour before the procedure.
Yeah, so my question is, what condition are you thinking about?
Infective endocarditis.
Infective endocarditis. Beautiful, beautiful, beautiful. So the drug for infective endocarditis prevention, okay? The drug for the infective endocarditis prevention is, as you can see, it's amoxicillin 2 grams PO times 1 dose. You give it about 30 minutes to 60 minutes before the procedure. So another lesson here, like what I've been telling you all this while. Someone can write amoxicillin 2 grams PO times 1 dose 30 minutes before the procedure. Another person can write amoxicillin 2 grams PO times 1 dose 60 minutes before the procedure, and both will be right. So the most important thing is just get one and keep it in your mind. Don't worry about, is it 30 to 60 minutes? Because if you write a range, that would be wrong. Even though you've gotten everything right, that would be wrong, okay? So I've written it again in yellow. Ranges were written for teaching purposes. In an exam, choose a single duration and stick to it. All right? Doctors, can we move on? Can we move on? Because for me, I think it's very important. And now you are seeing how you can have one question stem with various questions underneath it to prepare you for this exam. So this same guy who is going for the dental procedure, your patient's allergy list later and realize that the patient is allergic to your first line medication. In other words, the patient is allergic to amoxicillin. What other option will you consider? Indicate the medication, the dose, the route, and the timing. So in somebody with a previous infective endocarditis who is going for dental procedure and the patient has allergies to amoxicillin, what else can you give, doctors? What else can you give? What else can you give in a patient who has allergies to amoxicillin, who needs prophylaxis before a dental procedure? What else can you give? Anyone? So I didn't hear you. Hello, doc, I didn't hear you. Okay, will someone else want to try? What other medication can we give? The other medication we can give can be clindamycin, 600 milligrams PO times 1, and that can also be given 30 minutes before the procedure or 60 minutes before the procedure. Clindamycin, 600 milligrams. Amoxicillin, 2 grams. So infective endocarditis prophylaxis for dental procedure, boom, we've learned it today. Okay. That same patient, list 2 other patients who may need the medications you provided in cases 6 and 7 above. So list 2 other patients who may need medications you provided in cases 2 and 7 above. So which other patients will need amoxicillin to be given before they get a dental procedure? That's all that the question is asking about. Anyone? Anyone? Which other patient will need amoxicillin to be given before dental procedure is done? Number 1, if the patient has a valve replacement. Number 2, patients who are 6 months post-congenital heart repair. And number 3, patients who are undergoing cardiac treatment, cardiac surgery with valve regurgitation due to a structural abnormal valve. These are the people. Okay? Okay, good. Now, case 9. A 20-year-old male came into the clinic with a history of stuffy, runny and itchy nose for the past 2 days. He has noted yellowish and greenish discharge today. What antibiotic will you provide this patient? I need an answer, doctors. Remember, this is therapeutic decision making. TDM, not CDM. CDM is for MCCQA1. TDM is an exam on its own. So a 20-year-old male came to the clinic with a history of stuffy, runny, and itchy nose for the past 2 days. He has noted yellowish and greenish discharge today. What antibiotic will you provide the patient? Dr. Asma said, common cold, no antibiotic. Beautiful. This is a concern a lot of patients bring to the ear. Oh, doctor, I have runny nose. It is yellow. It is green. I think I need antibiotics. No. And Dr. Asma nailed it. So in this case, this is one of the cases where I would say no treatment or like no antibiotic, because yes, we give treatment. We do symptomatic treatment, Tylenol, Advil, hydrate, rest, salt water gargles and all those things. But I will not provide any antibiotic. And there's an interesting thing in RX Files, volume 12, or the 12th edition, page 100. Do not prescribe antibiotics. It says yellow greenish discharge is not indicative of bacterial infection. And all these things, Medcognito has put all of them together for you, so it makes your learning easy for the TDM exam. Okay, let's go to another one. So this same patient we talked about that we said we're not going to provide any antibiotic. What treatments would you recommend to that patient? What treatments will you recommend to the patient? A patient with common cold. I think every doctor should be able to manage a patient with common cold, right? So what treatments will you offer to the patient? Does somebody want to speak, please?
NSAID.
NSAID, sure, for pain management. And what else? What else? NSAID. What else? So decongestants, saline nasal irrigation, steam inhalation, Tylenol, Advil, if the patient has any fever, right? But then decongestants, saline nasal irrigation, steam inhalation. Doctors, please, are you all tracking with me? I don't want to move fast, please. Are you tracking with me? If you are tracking with me, let me know. Let me know. Type in yes, 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 yes. I've just gotten 2 yeses. There are more than 30 people on the line today. 3, 4. For only 4 yeses. Only 4 people are following. Okay. 5. Good. Okay. So now let's get into this. Beautiful. Now people are responding. Awesome. Okay. A 79-year-old woman presents with chronic back pain, adequately treated with acetaminophen. You perform imaging. X-ray reveals generalized osteopenia, a vertebral compression fracture at L2, and wedging of the thoracic vertebrae. Please follow it carefully. This patient has come with chronic back pain. It is adequately treated with acetaminophen. Okay? And you perform an image indicating X-ray shows generalized osteopenia, vertebral compression fracture at L2, and wedging of the thoracic vertebrae. What class of medication may be prescribed for this patient? Please, someone should just unmute and talk to me. What class of medication will you prescribe for this patient? Yeah.
Okay. So the class should be biphosphonates.
Bisphosphonates. Beautiful. Okay. Name one contraindication to this class of medication.
Contraindication would be if the patient is unable to sit up for like 30 minutes.
Does someone have an alternating answer or an alternative answer? Of course, we'll give bisphosphonates because we are seeing symptoms of osteopenia and possible osteoporosis. But what is one contraindication? So the medication we'll give is bisphosphonates, okay? What's one contraindication? What are the contraindications for bisphosphonates? Number 1, Barrett's esophagus or esophageal stricture.
Esophagitis, okay.
Esophageal motility abnormality or echalasia. Number 3, if the patient has chronic kidney disease. Number 4, impaired renal function is the same as chronic kidney disease. And what you said, inability to stand or sit up for 30 minutes after drug injection. Why is it so?
Is it for the last one?
Yes, because that's what you were saying, right?
Yeah, because of the effects on the esophagus, it could cause that erosion if it stays there without, the gravitational pull down. It will cause esophageal ulcer and erosions.
Yeah, beautiful. So you have to be able to sit so that it can really drop into the stomach, right? Okay, good. And then we asked that what potential long-term serious side effects of the drug or medication should be disclosed to the patient before prescribing. It can cause osteonecrosis of the jaw. It can cause osteonecrosis of the jaw, or it can just cause osteonecrosis. So you want to let the patient know that, look, the medication you are taking, it can lead to osteonecrosis. Okay. Let's one non-pharmacologic intervention that should be considered for this individual. So somebody with bad osteoporosis, what non-pharmacologic intervention should be considered? Number one, fall prevention. Number two, physical activity. Number three, weight-bearing exercise. Fall prevention, physical activity, weight-bearing exercise. These are the non-pharmacologic. And remember that what percentage did we say percentage of questions will come from non-pharmacologic cases, please? Can somebody remember percentage of cases that will come from non-pharmacologic cases? Who can tell me? Non-pharmacologic. Non-pharmacologic. What percentage of cases will come from non-pharmacologic cases? It will be 30%. And then pharmacologic cases will be 70%. Okay? Sure. Okay, let's go to another question. So a 30-year-old man see you in your office complain of low mood for the last. Okay. The patient has been complaining of low mood for the past 3 months. He had a previous similar episode 7 years ago. He cannot concentrate at work and has insomnia. After questioning him, you diagnose a major depressive disorder. After questioning him, you diagnose a major depressive disorder. Number one, what 3 non-pharmacologic steps would you consider? Number two, you decide to prescribe an antidepressant medication. When would you ask him to follow up with you in your office? And number three, how long would you continue this prescription if it is effective? What 3 non-pharmacologic steps would I consider in a patient? This patient obviously has depression, right? So what non-pharmacologic steps would I consider? Or non-pharmacologic steps would I consider? Number one, you want to ask about, suicidal ideation. Number two, you want to ask about family and other support, like, interpersonal relationships. They have support of a counselor. If not, you want to get them in touch with all that. And you also want to rule out hypomania. Hypomania is because, the case says that the patient has had a similar thing 7 years ago. So you want to make sure that there's not full-blown bipolar and there's not, hypomania. And then, of course, you can also consider other treatments like cognitive behavioral therapy, interpersonal therapy, family therapy. All those are non-pharmacologic options which can help the patient. Then you decide to prescribe an antidepressant medication. When will you ask the patient to follow up with you? Usually, it's 2 weeks. 2 weeks. Because around that time, the patient's energy is going up, but their mood is lacking. And that is when a patient with depression may, I didn't say will, may likely have the strength to carry out any suicidal or homicidal tendencies they may have. So that is when you want to touch base with them, when they start taking their antidepressant medications. And for how long will you continue this prescription if it is effective? At least 24 months after resolution of the symptoms. Because these patients have had it before. So you want to be very careful. You don't want to just do 12 months. That's 1 year and stop. Maybe 24 months. If the symptoms resolve, then you can taper down and stop. Doctors, please, is that clear enough? Depression, we've looked at depression management. Okay. I have another question. A 40-year-old woman with severe rheumatoid arthritis has been treated with high-dose steroids for 6 months. Give 3 potential side effects of this medication. Give 3 potential side effects of this medication. So what are the side effects of steroids? That's all I'm asking you. What are the side effects of steroids? Steroids. Yeah, Dr. Asma is answering some questions. Dr. Allah is also answering some questions. Side effects of steroids, Cushinary state, osteoporosis, hyperglycemia, pseudotumor cerebri, cataract, striae, obesity, easy bruising, high blood pressure, diabetes. All of these are side effects of opioids. All of them are side effects of opioids. So what I would do is that I will copy these links and put them in the Facebook group so you can go directly to them, because these links contain a total of 8 sample questions. 3 sample questions from the CPSA, that's Alberta, and then 5 sample questions from PRABC, that is British Columbia as well. So my question is, are you ready for this?